So we're talking about insect stings as part of an anaphylactic reaction. We were talking about putting ice on it. If that's a localized reaction and you don't have any of these severe anaphylactic symptoms like those that are seen on your screen right now, not a big deal. If you have any of the symptoms that are listed on the screen, you have more things to worry about than just applying ice. Definitely a good afterthought if you get the bronchospasm under control and the blood pressure up, but not something that you want to focus on initially, just in case. With patients that experience anaphylaxis, they proceed to death very quickly. More than, excuse me, 2/3 of patients who die of anaphylaxis do so within the first 30 minutes of their exposure to whatever stimulus started the reaction. So rapid transport so that they can get definitive treatment is absolutely essential. When we're looking for the scene size up, definitely want to look around very closely to see if you might be able to get some clues as to what may have caused the reaction. Trying to see if you see any sort of insects that might be suspicious, food allergies, looking at like if they're at a restaurant, what types of additives do they use or cooking oils or whatever, because it might be tree nut related. Any sort of new medications. And also keep in mind that any patient that's complaining of some sort of respiratory issue may be an allergic reaction, and the patient just is unaware that they have that specific allergy. So until that field impression is firmly established on allergic reactions, be mindful of all of those other differentials. Make sure that you're looking at everything. Because a lot of times if somebody is wheezing and having a hard time breathing, we just go, yeah, well, no history of asthma, so this has to be an allergic reaction. Make sure that you don't jump to that conclusion too quickly, but know that that's definitely a differential there. A traumatic injury may just as easily present close to or similar to anaphylaxis. And if you are thinking it's going to be anaphylaxis and you're not going to be at the hospital very quickly, ALS, because we do have injectable epi and Benadryl and steroids to kind of help slow down the reaction, if not stop it. For the primary assessment, you're going to very quickly assess the ABCs for those potential life threats. Oftentimes, you're going to have a problem with A, B, or C, and they can quickly deteriorate if they are in true anaphylaxis. You want to form your general impression. Any sort of allergic reaction may initially present as like a respiratory condition or cardiovascular issue, and they'll look like they're in shock, basically. Patients with severe anaphylaxis typically are very anxious because they're having a hard time getting that oxygen in. They oftentimes are lightheaded because they're having problems maintaining a decent blood pressure. If your general impression is somebody that's anxious, in distress, and you're not sure what's going on, go ahead and call ALS and then initiate transport very quickly. Look for medical identification tags if your patient is unresponsive or unable to answer your questions. Airway and breathing. So anaphylaxis causes very quick swelling of that upper airway and then leads to bronchospasm in the lower airways. Not all allergic reactions end up progressing to anaphylaxis, but we still want to quickly assess to make sure that the patient's not in anaphylaxis already. And then we do a lot of reassessment just to make sure that the patient doesn't progress to there. So every few minutes, you should be assessing the airway and determining the severity of the symptoms and whether they're trending to feeling better or trending to feeling worse. You want to look for any of the signs and symptoms of difficulty breathing with patients that have anaphylaxis. Your wheezing is going to be because there's narrowing of the airway passages because of that bronchospasm, and they're going to try to force the air out, which causes that whistly sound. That's why it's normally only on exhalation. If somebody is having an inhalation and exhalation wheeze, they're in a very bad state. They're having a hard time not only getting the air out, but also now getting the air in. It can actually continue to progress to the point where you're not going to hear a wheeze. They get so tight that there's no turbulence of that air flowing through there. So you may actually have diminished breath sounds. You can also have what's called stridor. That's a really high-pitched, kind of musical-ish note. And that's from your actual larynx. So your vocal cords, the area that your vocal cords is contained in, that is starting to swell. And that's heard on mostly inspiration because you're having a hard time getting the air in. If a person doesn't have some sort of treatment for the stridor and the severe wheezing, they're going to progress very quickly into respiratory arrest because they're just going to get tired from having to work so hard to breathe. And once you get into respiratory failure, cardiovascular failure tends to follow very, very closely. So you want to put the patient into a comfortable position to try and make it so that they can breathe as easy as possible. A lot of times your patient's going to want to sit up. If you are suspecting shock symptoms, if they will tolerate it, and most often they will not, you can put them in a supine position so that the blood doesn't have to work so hard against gravity to get up into the head. Initiate high flow O2. They're going to be short of breath, so put it on there. I know it says as necessary, but when they're having some sort of respiratory issue, throw it on there. If they are having severe enough distress, you can actually assist ventilations with a bag valve mask. You're not taking over their airway, you're just assisting them with getting air in, and then they'll have to figure out how to get it out. Oftentimes they'll breathe through pursed lips because that kind of helps. But we're more worried about getting the air in than we are necessarily of getting it out immediately. For circulation, if they're in anaphylaxis, they're going to show symptoms of shock, particularly hypotension, because of that blood vessel dilation that's going on throughout the body to try and bring substances to battle whatever it is that set off this reaction. So a lot of fluid from their blood is going to leak into their tissues, and there won't be enough contents within the container to actually have a decent blood pressure. You want to palpate for the presence and quality of that radial pulse. Remember, as their blood pressure starts to drop rapidly, they could actually lose the ability to create that radial pulse because their blood pressure has gotten so low. You want to assess for not only is it there, but is it rapid? Checking out the skin, is it pale? Is it cool, cyanotic, or red? Is there delayed capillary refill time? This will help you determine if your patient is having issues with hypoperfusion. We're going to treat for shock, so oxygen positioning as tolerated, preventing loss of body heat, so keeping them warm. But the definitive treatment for anaphylaxis is definitely epinephrine. And then there's a couple other medications that we throw in just to help with the symptoms. Transport decision, if anaphylaxis is suspected, or if they seem like they're okay when you first get there, but they're progressing to this could be bad, you want to transport very quickly, take along medications that could be the suspect, etc., or thoroughly document what those were. If the patient is calm and doesn't exhibit severe symptoms, you may want to stay and play a little bit to get some more information. But most of the time when they're experiencing some sort of allergic reaction, we tend to move a little quicker than more often than not anyways. For history, you're going to investigate that chief complaint, try and identify all the signs and symptoms that are present, and then we'll continue on to get a sample. But I'll leave this table up here for a minute, table 20-1, which are all the different signs and symptoms of an allergic reaction. So you get a lot of fluids draining just due to the vasodilation, and it oftentimes ends up activating all of your mucus receptors. So all of a sudden now you've got a runny nose, you've got pale, sweaty skin. If you go all the way down to a decreasing mental status, that's also showing you that they're not perfusing well. So go ahead and take a look at this in your book, and you'll have some more idea of what's going on. We'll follow with our sample history and ask them if they've actually already treated themselves for this and it's just not working. Some people that have a severe allergy and have gone into anaphylaxis before will have an EpiPen. So ask them if they've taken it. And then, has this ever happened before? And then can you tell me about that a little bit more? So that you know, well, yeah, last time I was intubated, meaning they put a tube down the patient's throat in order to control their airway because the swelling was so significant. If they tell you that, move. You don't want to have them in your rig when they go into respiratory arrest. If they've been intubated before, chances are they're going to need intubated again. So can be pretty darn scary. Be alert for any statements that regard the ingestion of food. When was the last time that you ate? Obviously, last oral intake does ask that question. But was there anything specific in that food that you may have been allergic to? And then ask them about GI complaints. So are you nauseous, vomiting, etc.? For your secondary assessment for your physical exam, if it's indicated they don't know what bit them, they don't know where, etc., you want to do a rapid head to toe just to make sure that you don't miss anything. If they know exactly where their bites are, you can focus on that area. If the patient is unconscious or can't communicate well, go ahead and remove clothing as necessary to look for any sort of bites. Look for medical alert tags. If you haven't already done so, you want to auscultate for abnormal breath sounds and then check over the skin to see if you're seeing any swelling, rashes, or any itching as well. For your vital signs can indicate whether your body is compensating or not. So you want to assess vitals pretty early so you can get a good baseline so you can tell if your patient is trending positively or negatively. Skin signs may be unreliable indicators of hypoperfusion because they can actually be hid by that swelling and those rashes and hives. So you may not get a really good picture of what the underlying skin signs are. You want to get your pulse oximetry to make sure that there we go. Because this can be a better method to looking at perfusion status. And then your decision to apply oxygen is based on how is the airway, what's the work of breathing, are there any abnormal lung sounds that I need to work on? But oftentimes they're going to say, yeah, I'm short of breath. So you're probably going to put at least a minimum amount of oxygen on them. and we'll continue later.